Welcome to the other side of Letby in episode 67, which is really episode 67, and not, as I said in the last podcast. I'm going to look at a subject that was brought to my attention by Stuart Gillam. Now, Stuart has a YouTube channel, and I'll leave you a link in the show notes. But I would highly recommend you to look at the channel and subscribe to the channel. His content is very good, very well researched, and very well presented. And people, I don't think, realize how difficult it is to make that kind of content. So give Stuart a look out and subscribe. Hit the subscribe button because that helps to circulate his great little videos as far as they can go. But Stuart, in his last video that I watched, raised the question of the incompetence or otherwise of Justice Goss. And because for me, that's a matter of opinion, and I don't know anything about the law, and increasingly care less, although I suppose that's a pretty irresponsible state of mind, given what I've had reinforced about the law and lawyers in the last year. I think we can look at this from another angle and consider the likely impact that Justice Goss had on the outcome of the trial by the decisions that he made and how they would have impacted on a truer story or picture of what was actually happening at the Countess Chester Hospital in 2015 and 2016. Now, I'm finishing my book and I'm on the last chapter now. And in the first chapter, I talk about Lucy Letby in general. And I use the lyrics from an Alan Parsons Project song as the introduction to the first chapter. And the lyric is, "And your world never ends when your whole world depends on the turning of a friendly card." And that is certainly something that didn't happen to Lucy Letby. At every turn, she didn't get the turn of a friendly card. And one of the people who didn't give her that turn of a friendly card was undoubtedly Justice Goss. So we'll look at some of the subjects that Stuart brings up in his video from a medical perspective. So he talks about two things, first of all, and that was the ruling, the fact that Lucy Letby had won a workplace grievance against these consultants. And apparently Justice Goss didn't think that this circumstance was relevant to a circumstantial trial. And we'll talk a little bit more about that grievance process in a minute. And the second thing that Stuart talks about is the refusal by Justice Goss to allow the admission of the Royal College of Paediatric and Child Health report into the Countess of Chester Hospital in 2016, which again is an extraordinary decision in a circumstantial case. We are told endlessly by people like Judith Moritz and Liz Hull that it was a constellation of evidence that put Letby behind bars and not just any one thing. Whereas I don't believe that for 1 second. Surely if you have a constellation of evidence, there's no problem adding another star to that constellation. Much argument is given in the Court of Appeal ruling about the jury's ability to decide what's important and what isn't, what is evidence and what isn't, what is fact and what isn't, what is believable and what isn't. Well, surely both the grievance hearing and the Royal College of Paediatric and Child Health report would have been in that realm where jury could have made their own mind up about whether they were relevant or not. But they were, but they never got to hear this evidence because of the decisions of Justice Goss. And whether that's incompetence or not, it's a fact. So Stuart says that on day 44 of the trial, Ben Myers starts to discuss the introduction of the RCPCH report into evidence, having previously provided the judge with a written submission shortly before this conversation. And he quotes Ben Myers as saying, "I should say it occurs to me as we've just served this on your lordship this morning. I anticipate it would assist for your lordship to receive hard copies in due course, and we can arrange for that. So we'll do that." Lucy Letby's defence lawyer Ben Myers makes the argument just by way of explanation. The report was prepared by a professional college, which the consultants are either members of or fellows of the college. And this Royal College of Paediatric and Child Health came about after the unit was downgraded from an understaffed level 2 unit to its proper designation of a level 1 unit that it should have been all along. And Mr. Myers says to Justice Goss that it would be surprising if this didn't feature in any narrative of what took place. And then Ben Myers argues that this isn't an instance of seeking the defence, seeking to introduce material that is outwit the knowledge of the witness or appears from provenance unknown or provenance dubious. Now, I presume that's some kind of lawyer speak for everybody knows about this report. And Justice Goss essentially says that I'm going to have a look at that because I think that the prosecution is likely to push back. And I would advise you to listen to it in the total context of Stewart's video. So we have what it appears to be Justice Goss acting as the prosecutor in the case and denying the RCPCH report. So what difference was denying that report and including that report? What difference did that have on how it would be possible to explain some of the deaths, or at least to give more circumstantial evidence into how those deaths occurred? Well, the RCPCH conducted a service review at the Countess of Chester Hospital in September 2016, and it was commissioned by the medical director Ian Harvey. And the review happened against the background of a cluster of infant deaths and collapses between June 2015 and June 2016. So the entire raison d'etre of the inquiry was the very subject of the Letby trial, the increase in mortality. And yet that was not considered to be a vital part of the evidence in Letby's trial. Now, another problem for the trial, or an outcome of the trial, was that the findings did not initially identify Letby or anyone else, but exposed systemic weaknesses in clinical governance, mortality review processes, which is really important, and institutional responses to staff concerns. The review found no definitive clinical or operational factors explaining the mortality spike, saying that they were not materially different, that circumstances at the Countess of Chester Hospital were not materially different from those in many other UK neonatal units. Birth weight distributions fluctuated, with a lower proportion of late gestation, that's over 37-week admissions, during the mortality period, but this was deemed insufficient to account for the outcomes. The report found that whereas 13 deaths had occurred between 2015 and 2016, and that is disputed, only 10 of them were reported as incidents, and that, crucially, the Cheshire and Merseyside Neonatal Network Clinical Effectiveness Group failed to detect the cluster, as deaths were not escalated properly. They also said that near misses, such as an infant requiring 3 nights of resuscitation, were documented anecdotally, but not formally analysed. So that doesn't read very well. But I'm going to give one example. Baby O and Baby P, that was the 2 monochorionic triplets, where it states in the report that they couldn't understand, that the RCPCH couldn't understand why that might have been a problem in terms of mortality, given that the neonates were 34 weeks, according to them. Well, they were actually almost 34 weeks. They were 33 weeks. So let's just look at what difference it makes where 33-week monochorionic, that's single identical triplets with single placenta and could have varying configurations of amniotic sacs, but they have a single placenta. What difference does it make if they're born in a level 3 unit where they should have been born, and a level 2 unit where they were born? And remember, this was a level 1.5 unit at best, because the findings of the RCPCH report was that it was never staffed to be a level 2 unit. Well, to begin with, for triplet pregnancies, cesarean section is the standard and recommended model for delivery, and it happens in more than 95% of cases. So when you admit triplets, you know that it's going to be a cesarean section. Now, triplets born at 33 weeks are almost certainly going to need admission to a neonatal intensive care unit. And the average duration of a triplet pregnancy is 32 to 35 weeks delivery, meaning at 33 weeks that it is well within the range where such admission would be expected. Now, regarding the maternal risks of the actual procedure, the cesarean section, 25% of mothers with twin deliveries have post-operative bleeding. And for triplets, the procedure requires very experienced surgical teams familiar with multiple births. Then there is the anaesthetic risk to the mother and the baby. And we have to recall that this was an in-labour cesarean section. So the mother was actually in labour with the triplets when the section took place. Now, the mother told the Thirlwell Inquiry that she was asked to sit in what her husband referred to as a filthy, dingy, unhygienic theatre. She was asked to sit on the side of the bed while ladies just injected something into her back. That's going to be a spinal injection right into the spinal cord, which will work instantly, or it's going to be an epidural where you're going into the little area between the fibers around the spine and the spine itself. And that's going to take 15 or 20 minutes to reach a reasonable onset of action. And given that the mother said that she could feel pain during the procedure, it's likely that she had the second an epidural. And as her legs were going numb, she was asked to put them onto the bed. Now, in labour is typically categorised into one of three categories. Category 1 is an immediate risk to life. And these require a rapid response. That's delivery ideally occurring within 30 minutes of the decision being made. And in some centres, that is expectation to move to theatre within 6 minutes of making the decision and 9 minutes in case of severe fetal distress. Now, does anyone think that the Countess of Chester Hospital had the capability of doing even 30 minutes, let alone 6 or 9 minutes? And category 2 would be a step down from that, but would generally be referred to for twins because it isn't completely unusual for twins to be born vaginally rather than by cesarean section. And that decision, the category 2, is that the delivery should occur within 75 minutes. And for category 3, you've got up to 8 hours. So it's reasonable to infer that BBO and BBP were in the second stage of labour. That is when the cervix was dilated 10 centimetres and some contractions were already starting. And given that these are triplets, monochorionic triplets with a single placenta, that is going to be a category 1 problem. Now, if it was the case that the pregnancy was in the second stage of labour, the increase in mortality for that alone is doubled automatically. Now, the time between deciding to perform the section and the actual delivery, which is the decision to delivery interval or DDI, significantly, again, impacts the outcome. A delayed DDI exceeding 30 minutes is associated with a 7-fold increase in perinatal death and almost 10 times higher the odds of having to go to a special care unit or a neonatal intensive care unit. So there we have an immediate 7-fold increase plus 10 times increase in going to a filthy, contaminated neonatal intensive care unit. And this is evidence that the jury shouldn't have heard. And studies show that 26% of these babies delivered by the emergency cesarean section experience adverse neonatal outcomes and 5.6% of them die within the first 7 days. Now, 5.6 doesn't sound like a big number, but I can tell you, in medicine, it is huge. Now, these monochorionic triplets have what's called almost universal vascular placental anastomosis. And that means the complete entanglement of all of their blood vessels from the placenta to the babies and back, all mixed up like a bundle of loose electrical wires. And the studies that we have show that these arteriovenous, so connections between arteries and veins, these are called anastomoses, occur in 95 to 99% of monochorionic triplets. Artery to artery, 80 to 90%, and venous to venous, 20 to 25%. And the net result of this is a 3 to 5 times higher perinatal mortality than cesarean sections for twins. So we're really rocketing up the risk factor here. So we can say with certainty that understaffed level 2 neonatal units are not adequately suited to managing preterm monochorionic triplets at 33 weeks. And the main risks are respiratory complications, tick for baby O and baby P, hemodynamic instability, tick for baby O and baby P, infection control, tick for baby O and baby P, and parental support, tick for baby O and baby P. Therefore, from a medical standpoint, all of this was predictable. And the most staggering statistic of all is that for each additional patient per nurse for this type of baby, and we've seen this happen all the time in the Countess Chester Hospital, where sick, needy, vulnerable neonates like this were not given one-to-one nursing. Each additional patient per nurse raises in-hospital mortality by 12%. Should a jury not have been told that? And the main reason for this is delayed surfactant delivery, inadequate monitoring, and poor coordination. And for that reason, according to the National Institute of Clinical Excellence and the British Association of Perinatal Medicine, level 3 units are mandatory for monochorionic triplets. And the staffing minimum recommended for triplet deliveries is 6 neonatal specialists, 2 to 3 per baby. And we're only addressing half the risks here, or not even half the risks. But yet the Royal College of Paediatrics and Child Health felt that, albeit 34 weeks, that this unit should have been able to cope with it. And just as Goss said about this report that got the basic management of these 33-week monochorionic triplets wrong, just as Goss said, it's not good just having bold assertions that there were shifts when there were understaffing and that sort of thing. Well, I've just read you the consequences of that sort of thing, predictably skyrocketing mortality. Now, one of the other criticisms in the RCPCH report, and which was admitted in court, was that there were only 2 consultant ward rounds a week, which is one of the reasons why the mortality in monochorionic triplets is so high, along with inadequate nurse-to-patient ratios, diagnostic limitations, that's the absence of echocardiography access, the inexperienced use of Optiflow, TIC for babies O and P, the absence of the NICE guidelines that monochorionic triplets require level 3 care because they need umbilical artery Dopplers and neuroimaging. And the Optiflow that they used, which is high flow nasal cannula, can mask deterioration in respiratory status. These babies also need blood gas analysis every 2 to 4 hours at minimum. And that is not the usual capillary blood gas analysis that baby O received one measurement of on day 1 of life. So is it any wonder that they didn't notice the decline in baby O because they weren't measuring for the decline in baby O? And they weren't measuring for the decline in baby O because they didn't have the nursing to patient ratios. And that is why the NICE guidelines recommend immediate transfer to a level 3 unit, which didn't happen. Also in baby O, by 40 hours of birth, the bowels hadn't opened, which is okay, provided there are no gastrointestinal complications. And also, the baby was now on full enteral feed within that 40-hour period and had no central venous access because it was on a level 2 unit, not on a level 1 unit. And when the baby did have a vomit, in other words, gastrointestinal complication, apart from the fact that the unit had missed the NICE guidelines of immediately transferring the baby, they had a second opportunity to do so because the failure to pass meconium, the first stool, within 40 hours is now highly relevant. And the net result of that was that the baby's next blood gas showed a pH of 7.2, metabolic acidosis, a lactate of 5.4, tissue hypoperfusion, a CO2 of 7.09, respiratory acidosis, and a bilirubin, early jaundice, beginning to form. Now, the two diagnoses that spring to mind are necrotizing enterocolitis and sepsis, or both, neither of which these units were going to be able to deal with. But it was also critical to know what kind of bilirubin was elevating. Was it conjugated or unconjugated bilirubin? Because if it's unconjugated bilirubin, it is a measurement of the breakdown of red blood cells in the tissues and not in the liver, which would have been an indicator of bleeding somewhere internally, which is precisely what happened to baby O. So there is another missed opportunity to make an early diagnosis because you're in a level 2 unit that is understaffed. And the response to this was that a junior doctor, of course, not a senior doctor, but a junior doctor, said that it was unlikely to be neck, and he ordered an abdominal x-ray, which is too little and too late, because baby O needed a surgical opinion immediately. So we have huge missing elements here that we call diagnostic gaps: stool analysis, a sepsis workup, and a contrast study. A contrast study is a specialized type of x-ray that's going to show you if there's any abdominal obstruction, which you should be worried about at this stage. Well, the result for baby O was only an abdominal x-ray. But what we're looking at here, disregarding the fact that the baby had an occult or unknown subcapsular hematoma in the liver, is a surgical emergency. So this 2:30 p.m. documentation captured a moment of profound physiological decompensation characterized by very ominous signs. Profound desaturation down to the 30s, bradycardia, metabolic and respiratory acidosis, and a lactate above 5, which is the depiction of cardiovascular collapse. And yet, Dowie Evans will go on to say that the 3 o'clock collapse of baby O came out of the blue unexpectedly, which is utter crap. And the documentation of mottled and abdominal red and distension is particularly alarming because it demonstrates to you that the marble patchy discoloration that you're seeing on the skin indicates poor peripheral perfusion and is a recognized sign of shock. So the patchy purple sign that Dr. Breary's seen, coupled with the mottling, strongly suggested an acute abdominal emergency, not the injection of air into a vein by Lucy Letby. So the documented signs in the agreed fact represent acute physiological decompensation of baby O, likely due to a catastrophic abdominal emergency, like advanced neck or volvulus, which is a twist in the bowel, and systemic manifestations like sepsis, and constituted nothing less than an immediate threat to baby O's life. Predictable, not out of the blue. Splinting of the diaphragm will not give you that blood picture and that clinical picture. It just won't. But given that we know that the baby died of a subcapsular hematoma, that's a bleed between the body of the liver and the capsule covering the liver, it wasn't, in fact, an abdominal emergency, but the obsession of these junior doctors with the diagnosis of NAC, which is known in medicine as an anchoring bias, meant that they didn't even consider any other diagnosis. And unfortunately, for subcapsular hematomas, the mortality rate is 85%. And it's 85% because they're so insidious and the onset is so difficult to detect, particularly if you're doing a blood gas once a day. So for the first 1 to 3 days of life, a subcapsular hematoma may not give you any symptoms at all, but it likely will give you measurements, data points and trends if you're doing them every 2 to 4 hours. And they are classically known for their misattribution of the symptomatology. So the early signs such as poor feeding and the pallor and the mild tachycardia are usually attributed to prematurity and respiratory distress and other feeding intolerance things rather than internal hemorrhage. And in order to make the diagnosis in life, you need abdominal ultrasound, you need serial abdominal ultrasound, and you have to have a targeted assessment for unexplained anemia or elevated unconjugated bilirubin. So what does the literature say about subcapsular hematomas? They describe them as systemic, non-specific symptoms that are followed by a sudden circulatory collapse when the hematoma ruptures. So the documented signs, abdomen looked full and slightly loopy, infant appeared uncomfortable after feed, no meconium, even though the baby had reached full enteral feeds, were all present, but they were ignored by bias and lack of experience. So that was the relevance of having the RCPCH report in the hands of the jury, which is only one part of Stuart's excellent video. This report provided essential context for this trial to be held in any way that anybody could call for. And we have to remember too the family reaction to what they witnessed with baby O and baby P, which are deeply troubling to anyone who cares about medicine. The mother described a scene of chaos where staff appeared to be in a state of panic. And I have been in situations like that where you need to actually kick out half the people that are in the room. And it's all down to lack of leadership. But we have to remember too, maybe the most troubling part of the mother's statement, that a young doctor was Googling how to insert a line during the critical care of baby P. Do you think anyone in the level 3 unit would have been Googling how to insert a line? And she said to the farewell inquiry that she was a little surprised at this, as I assumed the staff knew what they were doing. Well, clearly they didn't. And the mother said that she didn't expect that a student nurse would be looking after her baby, with Lucy Letby popping in and out. But Lucy Letby was popping in and out because she wasn't on a one-on-one allocation and she was going to other babies. And like everyone else in that unit, they had become conditioned to this type of behaviour. We had, during the resuscitation, Dr. Gibbs asking Lucy Letby how many adrenaline doses had been administered. And this fits in with the research that we know, that aligns with papers that show the findings of chaos, inexperience for NICU parents, and a characteristic feeling of confusion and desperation commonplace in the parents, who are essentially ignored, which are serious ethical concerns for the practice of medicine. And remember, the family described the difference between the Countess of Chester Hospital and Liverpool Women's Hospital as night and day. And they were made to wash their hands before they even came onto the unit in Liverpool, whereas other mothers noticed the nurses never washing their hands, moving between patient to patient in the Countess of Chester Hospital. So for this short podcast, by my standards anyway, we can see that the RCPCH report could have provided a structure for the defence of Lucy Letby, because in each of the cases, the systemic failings of that unit were outlined in that report. Even though it wasn't a good report, it was good enough to allow Ben Myers to structure a defence around. But he was denied the opportunity by a decision from Justice Goss. Now, whether that's incompetence or not, I don't know. But it's certainly not fair, particularly in the context of what we're told was a largely circumstantial case. So for those of you who are interested, I'll leave a link to Stuart's work and I highly recommend it. It provides me with great insight, and I'll see you in the next episode. Bye.